everyone, especially those who have newly joined us, to introduce about this concept. So what this forum is all about. So good evening and a very warm welcome to everyone for yet another session of Brendos. Brendos is an online forum where on a monthly basis we meet and interact each other and discuss about breast and endocrine related cases on an alternative basis. So on odd months we usually discuss about endo cases, and on even months we discuss about breast cases. How our forum is different from others, because in this forum we try to see the patient as a whole. So along with the clinical presentations of the patient, we try to discuss the original histopathological and the radiological images with the help of the experts, with an idea, so that like whenever we try to see those images, we have an impact. An image is formed in our mind about how these images actually look like, on basis of which the histopathologist and the radiologist or the nuclear medicine physicians, they make the reports. Not only that, these people like pathologists, pathologists, radiologists, and the nuclear medicine physicians, they also understand how their reporting have an impact on the management and the ultimate outcome of the patient. So in this forum, we integrate almost all the specialities who have been involved in the management of that particular case. Okay, so we see the patient in a broad sense, and it has a it makes a deep impact on our mind also, so that the whole idea is to improve our practice in a better way. Okay, so today we have a very interesting case, and I request our moderator, Dr. Anju Rastogi, ma'am. She is one of the renowned infertility expert, a very senior obstetrician and the gynecologist of the city, with very good name and fame. And she has an infertility center, and she runs a very successful center out there. And I'm very fortunate ma'am has consented to take part in this activity, not only as a participant but to help me as a moderator also. So I request ma'am to please start the meeting and to introduce our guest faculties and all. Thank you, ma'am.
She is muted.
आप करो.
Mute himself.
Ma'am, you are muted.
Yeah. Can you hear me now?
Yes, ma'am.
Thanks a ton, dear Sudhi, for your kind words. And a very good afternoon to everyone present for this webinar. It's really a moment of great pride and honor for me to be a part of this platform. And I'm thankful to Dr. Sudhi for giving me this opportunity. Today we have a very interesting topic for discussion, and that is hyperprolactinemia management in females of reproductive age group, focusing mainly on infertility and pregnancy. As we all know that hyperprolactinemia is amongst the most common causes of secondary amenorrhea, and even it may result in delayed puberty and primary amenorrhea if it arises before puberty. So it is very important to know in details about hyperprolactinemia. It's a very important as well as very interesting topic because the accurate treatment gives very good results also. And for the discussion of this topic, as Dr. Sudhi said, we need multiple specialties. So today, therefore, we have a forum with many specialists and stalwarts of their own fields. I would like to introduce the faculty for this discussion, and I'll start with the faculty from our own city, Dr. Sudhi Kamboj, who is consultant and head of Department of Breast and Endocrine Surgery, Tumor Hospital, Meerut. Then we have Dr. Meena Bambi, who is a consultant radiologist at Healthcare Imaging Center, Meerut. Dr. Chani Jain, who is a consultant pathologist at Shastri Nagar Diagnostic Center, Meerut. And then we have two faculties from outside, from very reputed institutes. Dr. Sushil Gupta, who is professor at Department of Endocrinology at SGPGIMS, Lucknow. The areas of interest for Dr. Sushil are osteoporosis, metabolic bone disease, endemic fluorosis, acromegaly, and renal stone disease. He has 102 research publications to his credit, and he's written 8 chapters in various books, and he's co-author of 4 books. He's ex-vice president of Endocrine Society of India, and at present he is vice president Education Foundation of SGPGIMS Lucknow. He has keen interest in academics. Welcome, Dr. Sushil, to this forum. Thank you so much for coming and giving consent for this discussion. Another guest faculty we have Dr. Mukta Agarwal, who will be joining us shortly. She is additional professor and unit head at All India Institute of Medical Sciences, Patna. She is MBBS and MD both from KGMCU, and she is gold medalist throughout her academic career. She has 45 publications to her credit in various reputed index journal, and her special interests are in gynae endoscopy, infertility, and reproductive endocrinology. So, you can see we have a very good team for this important topic. Before handing over the forum to the faculties, I would request all the delegates to please keep their mic mute so that we can have uninterrupted discussion. And if there is any interruption during the discussion, you can always rejoin from the same link. You can put your queries in the chat box, which we can discuss at the end of this discussion. So, over to the stage is to the faculty. Over to you, Dr. Sudhi, and your team. Thank you so much for giving me this opportunity once again.
Thank you very much, ma'am. Now I am sharing my screen. Share. Okay, okay. So, is my screens visible to everyone?
No, not so. Yeah, no, it's there.
Fine. I'm extremely sorry for the network issue, but like it's something boon as well as this also sharp also like now there are limitations also. The network is relatively slow. I request everyone to please bear with us, and thank you very much, ma'am, for this kind introduction. And I'm glad that we are back again with yet an interesting case of a patient with a interesting case of a 28-year-old female actually who presented to us with a left acute suppurative mastitis for last 3 days. She, along with that, she had galactoria for 2 months and amenorrhea for 3 months. When we inquired about her when we inquired about her personal history, we found out that she had an active married life for 2 years, but she was primarily infertile, for which she was planning to seek some treatment. So, other than that, she didn't have any other comorbid condition. So, friends, this is the video I've purposefully kept here so that we have an impact and understanding in our minds so how this patient actually looked like. So, you can appreciate that she had this frank galactoria, and there was a frank pus, aspirable pus cavity. So don't get misled by that this cavity, this pus is freely aspirable. So this patient is can be managed medically. Usually these type of pus are multiloculated. So they require surgical intervention, which we also did in our case. So we did an incision and drainage, and following which we managed her with a vacuum assisted dressing, with which she had a very good response, and we were able to provide her this much of cosmesis after secondary suturing. So the thing was like though we managed her breast abscess, but the thing was clicking in our mind ki why she had this galactoria when she is not pregnant and she was not lactating. Since she was amenorrheic, we first ruled out pregnancy out, and we ruled out the other physiological factors also. She didn't have any history of drug intake. There was no history of pelvic inflammatory disease, head injury, and other things. We did the blood work, and we found that her liver and the kidney functions were normal, but her prolactin was high. It was twice the upper normal limit of that lab, and her TSH was also mildly raised. So, since like at this much of hyperprolactinemia, usually we don't ask for any other workup. Usually we consider it as mild. But when we further inquired about her history, we found that she had a strong family history of brain tumor in her chacha and bua, the records of which were not available to us. So, keeping everything in our mind, the patient was also relatively apprehensive. We planned to do a screening MRI brain in her case, and we sent her for MRI brain. And I request Dr. Meena to describe those images to us.
Hello, good afternoon, everybody. Thanks, Dr. Sudhi, for referring the case to me. In a patient with a history of raised prolactin, we generally do dynamic contrast enhanced MRI brain to rule out pituitary adenomas. So, pituitary adenomas, normal pituitary gland is generally divided into two main sections, anterior pituitary and posterior pituitary, and it is connected to a hypothalamus through a pituitary stalk. Here you can see in the coronal images, this is the main pituitary gland. The big yellow pointer is pointing to hypothalamus, and above that is the optic chiasma. In a dynamic scan for pituitary gland, next image, uh, small FOV corneal images are taken at multiple locations through the pituitary glands after giving contrast injection at 5 seconds, 30 seconds, 45 seconds, 60 seconds, 90 seconds, and 5 minutes after the scan. The purpose it is used this particular technique is useful for identifying the adenoma, as the any lesion in the pituitary gland shows less enhancement as compared to the normal pituitary. In this particular case, next image. In this particular image, as you can see, there is well-defined intense lesion on the right side of the pituitary gland, which is showing less enhancement as compared to the rest of the gland. So in this case, in history of raised prolactin and such a hypointense lesion, we say this is a microadenoma as the size is less than 10 mm. Thank you.
Okay. Thank you very much, ma'am. And based on this report, since we could I'd see there was a space occupying lesion in the pituitary, and she had this this hyperprolactinemia. So we labeled that patient as having hyperprolactinemia with hypothyroidism caused prolactinoma. So we then managed the patient. We started her on dopamine agonistic drugs, caberlin 0.5 milligram twice weekly at bedtime, and tablet altroxin 25 microgram daily before breakfast, and with which she had a dramatic response. Her galactoria subsided and her menses resumed. But then a problem again arose when this patient showed her desire for pregnancy, because that particular time we were stuck. There were so many questions coming into our mind, like, suppose if the patient gets pregnant, then should we what will be the fate of the tumor? Will it increase or remain same, or it decreases? Most probably it will increase. And suppose it will, if it will increase, then how we will follow this patient, either with prolactin or with MRI? Should we continue with the drug or not? So there were so many questions, and we were not comfortable. Like, we thought ki there is something we need to discuss about, and that's why we put the case in this forum, so that we can have a brief revision of the prolactinoma in the context of the latest guidelines, as well as we can find out the significance and management of prolactinomas in infertility and pregnancy. Okay, so right. So friends, we all know that prolactin is a polypeptide hormone, just like growth hormone or the thyrotropin releasing hormone. It is synthesized by the lactotrophs in the anterior pituitary, and it's primarily involved in the milk synthesis. It has a hypothalamus has a huge impact or the control on the prolactin secretion. How? Two important chemicals we must remember are secreted by the hypothalamic nuclei. First is the dopamine, which through the pituitary stalk comes into the anterior pituitary and exert an inhibitory effect on the lactotrophs, thereby decreasing the prolactin secretion. The other chemical is the thyrotropin releasing hormone, which is circulated through the blood. It also acts on the lactotroph, but it has an stimulatory effect. So TRH is primarily secreted for the stimulation of TSH secretion, but side by side, it also helps in stimulation of the lactotrophs, leading to prolactin secretion. So there are many causes which leads to this prolactin secretion. The most important ones are the pregnancy and the lactation, nipple stimulation. Other than that are the chest wall stimulation. So how chest wall stimulation? A patient is having herpes zoster infection or there is a superficial burn. So this lead to the irritation of the superficial nerve endings, and this indirectly leads to the stimulation of the lactotrophs. Other factors are sleep, stress, exercise, and orgasm. But these factors are usually transient. So there is some pulsatile or fluctuating levels that we get depending upon the cause. And usually the average blood prolactin levels are within the mild range. So they are usually maximum 2 to 3 times above the upper normal limit for that lab. Then there are pathological causes also which lead to hyperprolactinemia. The most important one is the drug. So there is a huge list of drugs that are responsible for hyperprolactinemia. The important ones are the antipsychotics, anti-epileptics, and anti-depressants. Other than that are metoclopramide and domperidone, which we usually give for our patients with dyspepsia or with vomitings. So these are the important drugs that we see in our day-to-day practice. Other factors are like primary hypothyroidism. So suppose the thyroid reserves are less, so FT3 and FT4 will come down, which leads to the stimulation of the TSS secretion. So how this TSS will be hypersecreted is through the hypersecretion of thyrotropin releasing hormone. So as we have already understood that TRH has a stimulatory effect on prolactins as well. So this indirectly also increases the prolactin secretion. Then prolactinomas, tumors of the lactotrophs. Now, any tumor which causes the compression of the pituitary stalk, like hypothalamic tumor or tumor of pituitary stalk itself, also inhibit the dopamine-induced secretion of the suppression of prolactin. Dopamine will not be able to come from hypothalamus to the anterior pituitary because there is an obstruction at the pituitary stalk, and this inhibition will be lost. Liver and the kidneys we know are the common organs used for the metabolism and the excretion of any chemical. Same for the prolactin. So whenever there is a chronic renal failure or liver dysfunction, this prolactin metabolism and excretion will be hampered and it may also lead to hyperprolactinemia. Pelvic inflammatory disease and head injuries are other common factors which are usually seen leading to hyperprolactinemia. So how these patients actually present to us? The most common presentation is menstrual irregularities. The other features are infertility and galactoria. So I'll be discussing about all these in detail. Like menstrual disturbances. This prolactin has an inhibitory effect on gonadotropin releasing hormone. Okay, so whenever this GnRH is inhibited, it leads to inhibition of gonadotrophins like SPSH and LH, and it leads to the inhibition of ovarian functions like follicular growth and ovulation. So this degree of suppression, it decides the pattern of menstrual disturbance. Suppose if there is a mild suppression only, then only the follicular growth will be delayed and the patient will of delayed menses. The cycles will be prolonged. If it is moderate inhibition, then a heavy bleeding. If it is severe, the estrogen deficiency syndrome, like postmenopausal symptoms or hypogonadism. Now, galactoria. Galactoria is one of the characteristic feature of hyperprolactinemia. And it is, when do we say it is galactoria? When there is a lactation, milk synthesis outside of lactation, then it's a galactoria. Fine. But it's not present in almost all patients. So whenever it is present, we always suspect having hyperprolactinemia. But in all hyperprolactinemia, we may not find this symptom. It's present in only one third of the cases because this milk synthesis not only requires prolactin but also requires milk secreting apparatus like developed breast lobules, ducts, and the presence of estrogen and progesterone. So, if any of these are missing, if the priming of the milk secreting apparatus is not good, then the patient may not have galactoria despite having hyperprolactinemia. So, one important point we all must know about it, whenever there is galactoria, it poses an increased risk for infection. Maybe it is a areolar infection or it's a breast abscess. It may lead to any sort of infection because this high flown blood milk is a or a static milk is a good culture medium for bacteria. So whenever this milk is not continuously expressed out, it remains static inside us. Then they are very prone for breast infection, which was the case in our patient. How we should, what is the significance and how we should manage it, that we'll discuss later. Okay. And now the clinical presentation, this infertility, friends, you can understand is present in a very limited subset of patients, though it is an important complaint, but in a very limited subset because only married patients who are desirous of pregnancy, they only complain of this problem. So it could be primary infertility or it could be secondary infertility. A bit about the clinical presentation in males. In males, the characteristic features of hyperprolactinemia, hormonal dysfunctions like decreased libido, infertility, gynecomastia, they are not very prominent and usually they are misled with some other factors. So, most of the time, the clinical presentations in males are overlooked and they present to us with macroadenomas or large tumors. Okay, and their usual presentation are headache. They usually present with either headache or some cranial nerve involvement or visual disturbances. The characteristic one is tubular vision. So we all understand that the how the clinical presentation in males differs from that in females, and they may also have hypopituitarism because this enlarging tumor then press upon the other normal cells and hamper their functioning. So suppose any patient comes to us in which we suspect the patient may have hyperprolactinemia, how should we follow this patient? How should we evaluate? So following the clinical complaints, now that we suspect and we want to rule out, we will do it with biochemical evaluation. Two important hormones we must always check out apart from the liver and the kidneys is the serum prolactin and thyroid function test. And suppose if we find any abnormality and suppose a biochemical diagnosis is confirmed, then we'll try to localize the lesion with the help of dynamic contrast enhanced MRI, as we have already discussed. So the management of prolactinoma depends on two factors. First is based on the symptoms, the other is based on the tumor size. So based on the symptoms, based on the symptoms, so three important symptoms I have already told: menstrual irregularities, infertility or sexual disturbances, or galactoria. Tumor size, we categorize the patient into two categories: microadenoma, tumor less than 10 millimeter, and macroadenomas, tumors more than 10 millimeters. So, whenever we meet any such patient, we first try to find out the cause, if possible. So, suppose a patient has some hypothyroidism, we first try to rectify the hypothyroidism by giving some supplements. And suppose if the patient, we see that the patient is receiving some treatment, some drug treatment, which is possibly the cause of this hyperprolactinemia, we will try to stop the offending drug or try to change it to some other preparation which has less side effects. But suppose if a patient, we know that the patient is receiving an offending drug, but we are not able to stop the drug because the clinical condition because of which the patient is taking that particular drug is also equally important, and we don't have any alternatives. Then what should we do? Then we will treat the symptoms. Okay, so suppose a patient, most of the patient, giving a dopamine agonistic therapy is something like Rambar. So it whenever we give the dopamine agonist, majority of the symptoms are subsided. But still, after, suppose we feel that after giving therapy, dopamine agonistic therapy for quite a long time, the patient is still having menstrual irregularities. Then after ruling out other factors, we may start her on some oral contraceptive pill or cyclical therapies. Suppose the patient has a galactoria, as already said, with dopamine agonistic therapy, this galactoria subsides. It shows a dramatic response. But still, we need to take care that the patient doesn't develop secondary infection because of that, for which we ask the patient to periodically uh, empty the breast, just press out all the milk so that the milk doesn't collect. Or suppose if the patient has already developed a secondary infection, then treat the infection according to the basic guidelines that we usually follow. If it requires only antibiotics, just give it. If it requires some incision and drainage, don't hesitate in doing that. And the infertility. So suppose after receiving adequate treatment, we are satisfied that the patient's prolactin levels are normal, but still patient is infertile. Then after ruling out other things, one may try giving ovulation induction agents in her case. So dopamine agonists, there are two important drugs that we give is the bromocriptine and the cabergoline. So now, based on the tumor size, suppose we have two categories: tumor less than 10 millimeter, tumor more than 10 millimeter. So whenever we feel that the patient has some CNS tumor, we always seek for neurosurgical consultation and always check for visual field defect as a baseline. The most important visual field defect, if ever we find, is the bitemporal hemianopsy or the tubular vision. So, what is the treatment? Friends, please take it as a message, like just as a keyword. The medical management is the first line management in treating prolactinoma, because it not only shrinks the tumor size, decreases the hormonal hyper-secretion, it also shrinks the tumor size as well. So bromocriptine is the drug of choice for females desiring fertility and pregnancy. However, bromocriptine has very high hematogenic potential and a lot of dizziness patient complains of. So cabergoline, which has relatively much better acceptability, is the drug of choice for prolactinoma in general. What about surgical treatment? Okay, surgical treatment is limited in very selective patients. Only those patients in which tumor is unresponsive to the best possible medical management. So, or there is a persistent or progressive visual field defect, in which case we do a transsphenoidal resection of the tumor, which is something like this. We go through the nose and through endoscope and other uh, things, we just see and resect out the tumor. Neurosurgeons can tell a better detail of it. So now if we summarize again, microadenoma, that is tumor less than 10 mm, first line, medical management is the first line. Majority of the tumors show very good response after 2 years of therapy. Macroadenoma more than 10 millimeter with or without visual field defect. Okay, medical management is against the first line of treatment, because majority show the response, and the surgery is indicated only if the tumor is non-responsive or progressive despite on regular medical treatment. So friends, one very important point we is mentioned in this slide, that even if there is a visual field effect, we should always try medical management first. So depending upon the severity of visual field defect, if possible, medical management is always attempted as a first line. If at all we feel that we are not getting an adequate response or the problem is increasing, then only we go for surgery. And if at all, if it is required, therapy is usually lifelong. Now, okay, what should we do when, like, our follow-up patient, already a known case of microprolactinoma, now becomes pregnant, or a patient with pregnancy, or uh, or any patient with a microprolactinoma with pregnancy now comes to you. So once pregnancy is confirmed, we should stop the drug immediately. Why? Because it has a dopamine agonistic effect. So we don't want any such drug to be given to the pregnant lady, because it has a deleterious effect on the on the child's development, the baby's development. Now, another question. Now, what should we do? Should we follow this patient? If follow, how to follow this patient? So, there's a very important guideline I received from Endocrine Society, which recommend against the routine measurement of prolactin during pregnancy. During pregnancy, reason: during pregnancy, we expect a physiological rise in prolactin, and it is usual, it is natural. Suppose if we follow the patient with serum prolactin, it is supposed to be high, then we may confuse ourselves whether this high rise in prolactin is due to the pregnancy or due to the tumor, and we will unnecessarily burden ourselves and the patient with this stress. It also recommend against routine visual field measurements and routine MRI. So, reason: because it is not at all indicated. Tumors do increase during pregnancy. They have the tendency, but usually they don't increase to that extent. So, we usually follow the patient with clinical symptoms only. Only in patients who have the persistent headache, or they have some new complaint like new onset visual symptoms or headache or anything else, only those patients we first do the routine MRI. And if we feel that the patient is having rise or increasing size of the tumor, only then we restart the drug. So whenever there is features suggestive of tumor enlargement, which is documented with MRI, only those patients we restart. Otherwise, majority we don't need to restart the drug again. So, friends, we are before ending the presentation with few very important questions, which already we have discussed. I would like you to answer which of the following statement is not true regarding prolactin secreting tumor during pregnancy. So I request you to please write down your answer, write down the option, and I request Anju ma'am to please see how much have put in the right option. Okay, now. Okay, so now, now if I discuss all these points, so there is A point says there is a risk of increase in size of the pituitary adenoma during pregnancy. Yeah, of course, friends, it is right. During pregnancy, because of the stimulation, hyper-secretion of the other hormones like estrogen, pituitary, there is an interplay of the hormones, and which lead to increase in the secretion of prolactin. So in this series, in this sequence, the size of the prolactin secreting tumor also increases, but it doesn't increase to that extent. Though it may show some increase, but usually the rate of increase or the absolute increase in the size is not that much. Okay, pregnancy should be terminated. Should we terminate the pregnancy? No, of course not. Why should we terminate the pregnancy? I have already told that most of the cases the tumor doesn't increase to that much extent. So it is always good, like if the pregnancy is desirous pregnancy, then after explaining the prognosis and the need for the close follow-up, we should first we should always encourage the patient to complete the pregnancy under close follow-up. Any point, if we feel that the tumor is increasing, then we may restart the drug. But it is not required to terminate the pregnancy at the first instance. Medical treatment should be stopped as soon as pregnancy is diagnosed. Yeah, absolutely true. As already told, we should stop the drug and just closely follow the patient, because it has a dopamine agonistic effect, which may have some issues with the growth of the fetus. Now, periodic checking of prolactin is of no benefit. Uh, Already discussed, periodic checking is of no benefit because there is already a physiological rise in serum prolactin. So it will unnecessarily create confusion and will add nothing to our management protocol. So the answer B is not true. Now, another question. This is the this is the last question. So please bear with me. A 25-year-old female, and I hope you will enjoy it. A 25-year-old female who experiences galactoria and amenorrhea for 8-week duration with history of irregular cycles. Which of the essays should be initially be performed? Okay, just 30 seconds, and I know that you all must you all know the answer. I just want to see who by mistake just write wrong option. Okay, so without making without delaying, uh, yeah, since we are discussing about so much discussion we are going on about galactoria and prolactin, so I don't know who because I'm not seeing the option. I'm not seeing who has written what, but still, of this patient had an amenorrhea, a reproductive age group female with amenorrhea. Whether or not she has galactoria or not, we must not get confused, and we should rule out the pregnancy first. So in her case, also we should do an SCG to rule out pregnancy, because it is the first and the foremost cause of amenorrhea and galactoria. Prolactin is the second important investigation that we must do after ruling out pregnancy. So one very important aspect we always get confusion in hormonal assays. It is very important is the sample collection and result interpretation. And I request our friend Dr. Chani to describe how should we collect the sample and how should we interpret the result. Thank you, Dr. Chani.
Thank you, ma'am. May I have the next slide? So while sample collection for serum prolactin levels, certain things have to be considered. Prolactin, it has a pulsatile secretion and it shows a diurnal variation. That means according to the time of the day, the levels will vary in the blood. So the highest levels are attained during sleep. That is, it increases during sleep, with peak levels being attained around 5 a.m. to 7 a.m. And after 2 to 3 hours after waking up, that is around mid morning, lowest levels will be found at around 10 to 11 a.m. So ideal time of sampling will be a fasting sample 2 to 3 hours after waking up, that will be around mid morning. That will give us the best results. So on an average, the normal range we consider between 1 to 20 nanogram per ml, although the normal range varies according to the type of immunoassays being used by different labs, depending on their sensitivity to different isoforms of prolactins. So broadly, if we'll consider, if the levels are more than 20, so multiple factors as were discussed earlier in the presentation also. So it can be, if it is more than 20, it can be idiopathic due to drugs, microprolactinemia, microprolactinoma, macroprolactinoma, then pituitary stalk interpretation due to compression by some adjacent structure, hypothyroidism, chronic renal failure, traumatic chest wall injury, hepatic failure, and polycystic ovarian syndrome. If the levels are more than 100 nanogram per ml, it will narrow down our list a little further, and the possible causes will include drugs, microprolactinoma, macroprolactinoma, and pituitary stalk interruption. If the levels are more than 200 or 250 nanogram, that it narrows down the differential considerably to a pituitary tumor, that is a microprolactinoma or a macroprolactinoma.
Okay, thank you very much, Chani. And few important points I would like to highlight here is as already as maybe if some neurosurgeon has joined us, they can help us in a better way. Otherwise, like what my impression is, many neurosurgeons they don't even do MRI if the if the levels are below 100 even. And but I think this microprolactinoma and macroprolactinoma, like they can have serum levels from any level, like mild, moderate, or severe. So in our case we had a small mild level, but still we were able to detect a microprolactinoma, though it did not make any major difference, but still. Okay, so friends, some take home messages I would like to share with you all. Prolactinomas are a frequent tumors. Even in mild cases, we may have prolactinoma. Many times they are under investigated, so uh, uh, we don't know exactly like how many tumors we actually miss, but they are frequent tumors. The most important clinical features that they actually present are menstrual irregularities, and infertility. Galactoria is a characteristic symptom, but it is present in only 30 to 40% of cases. In males, because of the hormonal dysfunction features are not that much prominent, so usually they present with large tumors. The key investigations are the prolactin, thyroid function test, dynamic contrast enhanced MRI, and visual field assessment. Hypothyroidism must always be ruled out in any patient with hyperprolactinemia. Treatment is primarily medical with dopamine agonist. Routine assessment of serum prolactin, MRI, and visual field examination is not recommended during pregnancy. And pregnancy with prolactinomas are usually uneventful, so there's no need to become panicky, and it is always wise to stop the drug and follow the patient with under close and keep the patient under close follow-up. And with this, I would like to thank you all for your patient hearing, and I would love to hear the comments and the feedback from the experts so that we can understand this disease, this entity in a better way. I'm now stop sharing my screen.
Thank you, Dr. Sudhi. It's a very interesting case, actually. There are a couple of odd points in this case. You have got Amenorrhea Galactorrhoea Syndrome with mastitis and suppurative mastitis, and you got and a pituitary tumor. And your prolactin is not markedly high. Normally, if you look at the slide project by Chani Jan, there is no sacrosanct range of prolactin levels for prolactin. That's one. It can range from either little higher side than normal, like 35 nanograms per ml, to any level more than 500 or 800 nanograms per ml. We say that prolactinoma is classically there when the tumor is very likely to be there when the prolactin levels are more than 200 nanograms per ml. And you are very sure of prolactinoma when it is more than 300. There are only 3 or 4 case reports of non-prolactinoma tumors secreting prolactin more than 300 nanograms per ml. There are only 3 or 4 case reports in the literature. The question arises, is this 38 nanogram per ml of prolactin level is due to prolactinoma or not? Normally, these kind of levels are not due to prolactin secreting tumors, but there is a catch here. If you are today's date we do all the assays of prolactin by chemiluminescence assay, and there is an entity which we know of a hook effect actually. What really happens, you got a very high prolactin levels because we use antibody based assay. So we have got anti-prolactin antibodies in the assay. When they get saturated, so the prolactin level is not measured properly. So we can have the falsely low prolactin levels despite prolactinoma and really high levels when we redo the assay in a diluted sample, like we dilute the sample by 1 is to 10 and 1 is to 100, and we get the high levels. So 38 nanograms does not fit classical prolactinoma, but we need to do the assay in dilutions, then the hook effect is goes away. It was very common in earlier radioimmunity assay, but still in tabulum assay the percentage is around 7% actually. So there is a catch here that one you should have repeated the prolactin levels in dilution, and you could have got the prolactin levels more than 100 or more than 200 nanograms per ml. Very likely. So clinical context tells me that you have got mildly elevated prolactin, but the symptoms are very classical of Amenorrhoea Galactorrhoea Syndrome actually. That's one thing. Otherwise, in a normal physiology, 38 nanograms is not very suggestive until as you are suspecting a hook effect. That's very important. Number two is you refer to the question that whether cabergoline can be continued pregnancy or not. Normally, microprolactinoma do not much progress in the pregnancy actually. There is a percentage of 2 to 5% during pregnancy that microprolactinoma, micro we are talking about, they progress actually in only 2 to 5% cases. It does not progress in a large number. But macroprolactinoma, they do definitely increase actually in pregnancy. There is always a risk of visual compression and the pressure symptoms because of increase of prolactinoma during pregnancy. And sometimes we have to use cautiously capgoli during the pregnancy to restrain the tumoral growth actually. That's all. Normally we say you treat the macroprolactinoma if it is very large, reduce the size, the chance of increase does not happen because you have already removed the prolactinoma. But sometimes, because when you start capgoli in these women, and if they're not observing any barrier contraception, they turn pregnant, and then there is a catch here. The question arises: is cabergoline teratogenic or not? That's the question. Why we stop it? Now we have sufficient data to say there is no randomized controlled trial in the literature, but what's the observational studies we have? There is no significant teratogenic effect of the cabergoline on the fetal development, on the outcome of pregnancy, and on the neonatal development. Very rarely, a few congenital anomalies have been reported. So, though the Endocrine Society guidelines says that please don't continue cabergoline during the pregnancy because we do not have enough amount of data on the teratogenicity of cabergoline. But in certain select situations, we may have to use cabergoline just to retard the progression of macroprolactinoma during pregnancy. Micro, you can definitely stop it and serially follow the patient with the symptoms of headache or any visual field defects. But macro, you require really a meticulous follow by doing the frequent visual field monitoring by perimetry. That's more important actually. And therefore, once you have got a perimetric problem, the abnormalities on perimetry, then you definitely go for MRI and restart a cabergoline in that kind of scenario. It's a very cautious approach. Some people practice it. I normally stop cabergoline even in macroprolactinoma. Serial follow them up with the MRI and perimetry and all these things. Another catch point is during pregnancy, the pituitary itself rises because of effect of the estrogen on the pituitary. The height reaches up to 13 millimeter. In prolactinoma, sometimes the tumor increases in the postpartum period actually. So another strong period of vigilance is required in the postpartum period within first 6 months of the delivery actually. That's one point. Another point is. Uh, Anything else? So these are the couple of observations. So Sudhi, you could have done the prolactin levels and dilution, and it is generally written textbook. If you have got a pituitary tumor and you are finding normal prolactin, repeat the prolactin in the dilution actually. Make it in 1:10 or 1:100. So that's it. I really appreciate Dr. Chani for speaking out when to take the sample actually. What really happens now, this is a period of commercial labs. The person picks up the phone and asks them to come tomorrow morning at 7 o'clock in the morning to get the samples done for prolactin, and they have just come out of the bed half an hour before, and their prolactin comes 45, 50, 60 nanograms per ml.
Sorry to interrupt you,
40.
Dr. Sushil. Can you please switch on your camera? We want to see your beautiful photo. Hello.
Okay, actually, there was just a moment. Yeah.
Welcome. Dr. Mukta has also joined us. Our A very famous, renowned neurologist, Dr. Rohit Garg, has also joined us. So thank you all for joining us. Please continue, Dr. Shrutil. Thank you so much for switching on your camera.
Thank you. Actually, because of video are slowing down the network, so I just switched off my camera actually.
Okay.
So
Okay, sir.
I really forgot what I was speaking out. I really forgot what I was
So
speaking about.
you were
Yes,
talking
yes,
about the sample collection in the morning.
Yeah, so the lot of referral we get of prolactin levels of 40 for your awakening, you give the sample. Normally they give the sample at 7 or 8 o'clock in the 8 o'clock in the morning, immediately 1 or 2 hours after arising actually out of the bed, and that gives rise to increased prolactin level. So one has to repeat the sample by 10 or 11 o'clock, not to take a heavy protein diet like lot of eggs or high protein diet, because that itself increases the prolactin to a certain extent actually. So one has to take care of these sample collections. And now, of course, Dr. Sudhi really emphasize the kind of drugs which are common, which raises prolactin. So one had to discontinue the drugs, and one of the commonest cause of hyperprolactinemia in clinical practice is drug-induced. A lot of women consuming psychotropic drugs because anxiety, like escitalopram, protherodine, and likewise drugs. So these really increase. So these are the few factors. Physiological factors should be recognized as one of the common cause of mild hyperprolactinemia. Thank you.
Thank you, sir. Thank you so much.
So Dr. Sudhi, what do you plan to? You plan to continue the capcoline in her because she has got
sir. This patient
microadenoma
presented to us.
10
Yes, sir.
millimeters. Do you want to continue capcoline in her? Uh,
Yes, sir. So actually, Abhi, she is sh- what whenever what the protocol I usually follow is whenever the patient after initial workup we feel that the patient is having some tumor like pituitary microadenoma. We usually attribute it to the because she had symptom and her prolactin was also raised, though mild, but still it was raised. So we give it for a long duration for 6 to 12 monthly, I check her MRI to see whether the tumor is regressing or it is progressing. So this is usually a protocol. Regarding pregnancy, she is still not pregnant. She is still under treatment, and but I think whenever she'll become pregnant, we will stop her drug and then follow her clinically only, most probably with MRI as and when indicated. Otherwise, usually I give the drug for a longer duration only. I have not encountered any patient in which the tumor has completely regressed. In one patient, the tumor showed some regression after 1 year, but after stopping tapering off the therapy, after a few months, she again presented with galactoria with a lesion in the contralateral lobe. So that was another point of discussion here. I didn't put that case in this forum, but I had this experience. So one patient, I had this experience. So one question I would like to ask from you, like you asked for a serial dilution because of hook effect. Because as soon as we see the report, in fact, as soon as the patient gives the sample, we start her on Cabal-T. Because report takes at least 24 to 48 hours to arrive us. We ask her, ki, okay, start taking the drug. So anyhow, if we ask the patient to again give the sample, should we ask the patient to again give the sample, or should we ask the lab to put a serial dilution in the sample which is she has already given when she was not on any drug? So what method do you prefer, sir? Because I am a bit skeptical once the drug is started. Any measure of the, like any assay, we will have some biased report because already the drug effect has started. Sir, you are muted, sir.
Dr. Sushil, please unmute yourself.
Yeah, yeah. Uh, in clinical practice of endocrinology, we receive the two ways of referral. Either the patient is referred with hyperprolactinemia as per the report, or the pituitary tumor is referred actually for hormonal evaluation. Now, if the pituitary tumor is there, then we always ask for prolactin to be done in dilution actually to remove the fear of coca fat. But if you have got hyperprolactinemia or Amenorrhoea Galactorrhoea syndrome, all Amenorrhoea Galactorrhoea syndrome are not because of prolactinoma, but high suspicion is there. So if you got Amenorrhoea Galactorrhoea syndrome, ask the lab to do the prolactin dilution also. So
So
critical
in
context
first
is
instance,
important.
okay. So in
Yeah, even
first
in the
instance,
process,
only we should ask the lab to get it in serial dilution.
exactly, exactly.
Okay.
If the
Fine,
Amenorrhoea
fine.
Galactorrhoea syndrome is there, then now you should ask prolactin to be done in dilution in the first row.
Understood, sir. And I
That's
will
important.
certainly try this technique, sir.
Yeah. There is
So,
another entity actually what we know as a macroprolactinemia, where you have got big prolactin or big prolactin, basal prolactin combining with the IgG molecule or a fraction of it actually. There, sometimes you get a prolactin say around 200, you don't have Amenorrhoea Galactorrhoea syndrome because that is immunogenic, but not bioactive. So in those scenarios, you won't have Amenorrhoea Galactorrhoea syndrome, but you have a high prolactin levels and tumor could be there actually. So there is another entity where we think of macroprolactinemia, and of course none of the research lab does the job of glycol separation where we isolate the macroprolactin and do the say if the macroprolactin the level declines by 60% or more, then we think of macroprolactins actually. So these are a few catches from the laboratory point to specifically Dr. Chani actually. She elaborated very nicely. If you look at her one of first slides, the even more than 20 to 100 and 100 200 more than 200, she has written microprolactinoma and macroprolactinoma across all the place range of this. So it's very important to emphasize that prolactin levels are variable right from upper limit of normal range to any range high as possible. That's important. So there is no range sacrosanct for prolactinoma. That's one thing. Very important to emphasize here. The possibilities are more. If it is more than 200, and definitely it is almost 100%, but it's more than 300 nanograms per ml. So these are the kind of figures one has to keep in mind. So even at 38, I would not say that it is not prolactinoma. I would not say. But definitely to play it safe, I would say do the prolactin in dilution actually to remove the chances of okay factor.
sure, sir. We'll certainly do whenever the patient comes to us next time. We'll see again, reassess again whether she really had this hormone secreting tumor or that wasn't some non-functional tumor, and we are the hyperprolactinemia is due to something else. We'll try
Yeah.
from this aspect. We'll review her again from this aspect as well. Certainly, sir. Thank you, sir. Thank you very much
And your
for your.
T4 is 7 micro units per ml. I think I really clearly don't remember the free T4 or total T4 levels in that kind of scenario. But this
Okay.
cannot raise a prolactin. This there could be a possibility of subclinical hypothyroidism in this kind of scenario.
Mhm. Sure, sir.
There is another
And so,
entity which I need to mention. Just let me just last point. I need acromegaly present Amenorrhoea Galactorrhoea syndrome without elevated prolactin because growth hormone has got lactogenic effect actually. So there is one possibility that you can have Amenorrhoea Galactorrhoea, but your prolactin is normal and growth hormone is high. So this is what we call it spasticity is spillover. So growth
okay.
hormone has got lactogenic action. So in acromegaly also you can get that kind of picture.
So one thing I would like to ask you, this Caberlin. So what dose you actually use, and for how long? How do you follow these patients, sir? at your
This
institute?
is very important actually. Normally we start the dose of 0.25 milligrams twice a week actually. The median dose of capoline in prolactinoma is 2 milligrams. We call it as capoline resistance when it is requirement is 2 milligram per week actually in the recent literature, but older literature tells us more than 4 milligrams per week actually. How long to continue is very, very variable. A lot of people require for a very many years actually. When to discontinue is a very important question. You are maintaining prolactin levels within a normal range, then you serially follow up with the MRI and see the prolactin levels. The chances of remission in these cases happen when there is no visible tumor on the pituitary on MRI, one, and you are requiring very minimal dose of cabergoline to maintain the prolactin levels within normal range, like 0.25 milligrams per week or maybe 0.125 milligrams per week actually. If if you're not finding any tumor visible on MRI and you are requiring minimal dose, then chances of remissions are pretty high actually. But again, these are the possibilities we give. But we stop the drug for about 4 to 6 weeks time or 2 months time. Then we repeat the prolactin. Sometimes it goes high, but uncommonly. So these are the predictors of remission when you're treating. How long is there? So these are the two targets. I want to tumor not visible on MRI, and I want the minimum dose of capvolin to be utilized for controlling prolactin levels actually. At that point of time, I would stop it. And it takes years to gather. Optimally, the literature tells you about 2 years, but my experience is many times you require for even 4 or 5 or 6 years also.
Uh, Dr. Mukta is with us.
Yeah, hi.
Yes. Uh, Hi Mukta, thanks for joining. Are you able to hear us?
Yeah, sure. I'm able to hear you.
Thank you very much, Mukta, for joining us.
Thank
And
you for
Mukta,
inviting, and I'm sorry for delay. There was a meeting going on, and I could not leave it.
no, we can very well understand being in a government institute or tertiary care referral center and being a gynecologist, it's really very difficult. And you have still found this time to join us. Like it's a great pleasure for us. And Mukta, just want to, because like you have a good experience managing infertility patients. So can you please share your experience regarding such patient? How frequently you feel like just giving Caberlin only help the patient resume the fertility? And whenever the patient becomes pregnant, what protocol do you actually follow?
Yeah, actually, before prescribing cyberbullying, we should work up the patient properly. Like from the very history, if you are in our days also, in a patient of infertility, we always look for Galactoria. We ask for Galactoria, and apart from Galactoria, it is important that we are not doing prolactin for each and every patient of infertility. So first we narrow down, it's not in our primary investigations. We just go by our history, our examination, and after that, if we found a history of prolonged cycles, history of abnormal milk secretions, then only we go for prolactin. And if we found that prolactin is high, then we should also look upon thyroid TSH values, because at time in patients with primary hypothyroidism also you can get a bit higher prolactin levels. But if you find that prolactin levels are high, patient is not taking any drugs, and then we go for, definitely we go for pituitary dynamic scan MRI, just to know in the baseline whether we are dealing with any pituitary microadenoma or not. And we do complete workup like perimetry and all. And after that, we start capgulin, as you rightly pointed out, uh, as per the dose 0.25 weekly or zero point 0.5 weekly as per the patient's weight. And yes, if hyperprolactinemia is solely the cause of infertility, patients do respond. And for our practice, if patients is having microadenoma, or if or not at all any pituitary tumor is there, then we go for we stop capgolene when patient conceives, and after that we follow as we rightly discussed. But if we are dealing with a patient with macroadenoma, especially if there is abnormal perimetry or tumor is compressing optic chiasma, then we do not, there are two school of thoughts. Few people switch over to bromocriptine. But bromocriptine again, it's a drug very notorious. It causes nausea, vomiting. Because the safety profile is bromocriptine is much far than capgolene. We have a huge data on bromocriptine that it can be safely given. But in my practice, I have continued a few patients on capgolene throughout the pregnancy, and we do not have any adverse fetal effect. And those patients could, the pregnancy went well, and so we may, right now guidelines are not very clear on capgolene. But yes, for bromocriptine, guideline says that bromocriptine can be given.
Okay, so basically, with bromocriptine, we have a issue with emesis or dizziness. Most probably, the
Yeah,
patient's acceptability is relatively poor
very
with
true.
bromocriptine compared to capability. Actually, I found some information regarding the bromocriptine is the drug of choice in pregnancy and infertility. So I'm not much sure about it. Anju ma'am and Mukta, they can tell us better way
Not for
of what
infertility,
to
but
use.
definitely for pregnancy, bromocriptine is the drug of choice. Yes, for capgolene also, people are thinking of capgolene, but yes, bromocriptine is also pregnancy if we need to give something to the patient.
Okay. Mhm.
I have a
Okay.
very interesting case to share. If I am permission, I have permission from Dr. Sudhi. Can I share a very interesting case of infertility?
Ma'am, sure, sure. We would love to listen from you.
It was related to polymeric form of prolactin hormone. The patient was a young patient of 28 years, presented to a gynecologist with primary infertility, and on routine investigation, she was found to have prolactin to the tune of around 200 nanogram per ml. Although her cycles were regular and she didn't have any galactoria. On MRI, she was found to have a microadenoma of pituitary, and the prolactin levels did not come down with any dose of cabergoline. So finally, she had a transsphenoidal surgery for the tumor, and the MRI done after the surgery found that there is incomplete removal of the tumor, and she was again kept on capgolin high doses. Prolactin did not come down, and the patient was not able to conceive. So she came to me with this kind of history. I evaluated the patient. I saw an endometrium polyp, so I did a laparohysteroscopy, which turned out to be normal tubes and endometrial polyp, which was resected. And again, I kept her on capgolin. The prolactin level did not come down, and she could not conceive also. And after 2 3 years, she spontaneously conceived with those high prolactin levels. So what I concluded was that this was all because of the polymeric form of prolactin. As Dr. Sushil mentioned, that the polymeric form is the bigger molecules of prolactin, which are measured in the bioassay, but they are not biochemically active. So this is very important, that when the patient has high prolactin levels and they are not causing any symptoms to the patient like menstrual irregularity or galactoria, we must think of polymeric forms of prolactin hormone. This was a very interesting case which I had few years back.
Yeah, thank you. Thank you very much, ma'am, for sharing your case, because now we have a better understanding that this
Yeah.
problem is, this entity is also there. So at least with this discussion, we are one level up. Like now we know that we should also consider this entity as well. So we have Dr. Rohit Kamboj with us. He is a neurosurgeon, and we are. I'm very thankful to him that he found out time from his busy schedule on my personal request, because I just wanted to, if Dr. Rohit can hear me. Uh, Sir, if possible, can you please guide us? Like, what are your surgical indications in any patient? Suppose a patient comes to you with a suspected prolactinoma. How do you assess that this patient really requires surgery or not? Is surgery a preferable choice, or you want to avoid surgery due to various reasons? So, can you please share your experience with us?
Yeah, uh, thanks for inviting me. It's a very lovely talk. So your questions are whether surgery to be done in the case of prolactinoma. So since the advent of cabergoline, we hardly found subjects who require surgery for prolactinoma, whether it be micro or whether it be macro. Even I have seen very large tumor being disappeared by a prolonged course of prolactinoma. We have seen huge tumor going washing away. They literally wash away. But there are some indication where we definitely do require surgery. Some of the indications are if a tumor comes with a bleed and the patient has decreased visual acuity and naturally pressure symptoms are there, so we have definitely have to remove the pressure symptom to save the vision. Some patients can present with CSF rhinorrhea, so these patients may require surgery because CSF rhinorrhea can lead to meningitis and other sequel. If the patient is not tolerating cabergoline for many reasons and the prolactin level is very high and the desire of pregnancy is too much, because the majority of the patients, the main problem is infertility. So surgery can help in these patients. So there are very few indications of prolactinoma that require surgery. Otherwise, majority of the patients do get better with cabergoline.
Okay, so if I can summarize everything, in microprolactinoma, usually because cabergoline has a very dramatic role, so we just give them on put them on cabergoline and periodically follow those patients. In certain specific indication, only we operate. One thing I would like
No,
to
no,
understand from you.
there is no need of operating patient of macroadenoma. Only indications are is of macroadenoma that present with complications. Otherwise, if there is no complications, there is no need of surgery. You can just follow the patients on cabergoline, and you will see amazing results.
Sir, one thing I would like to understand from you, you mentioned CSF rhinorrhea. So, is this CSF rhinorrhea because of the tumor or something else? Tumor plus something else, and because of that we operate.
Some patients have thinned skull floor. So when the tumor is large enough, the pressure of the tumor erodes the floor of the skull base. Then these patients, because of the erosion of the skull base, the floor being eroded, or the tumor is of invasive variety, these patients can present with CSF rhinorrhea, but it is very rare.
Okay. And sir, one thing would like to understand from you, uh, 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 how frequently, like any patient you put on cabergoline, so what is your approach? How frequently you monitor the patient with clinical assessment, with MRI or serum prolactin?
Yeah, the main assessment criteria is of naturally is of serum prolactin level. We do it 3 monthly. Otherwise, clinical examination and clinical history taking is of utmost importance. The patient will herself complain about the whether she is getting benefited in the milky discharge or whether she has started in menses. So we can definitely follow her with the clinical examination. There is no need of frequent MRI and serum protein level.
So how frequently you advise for MRI to see whether the tumor is really responding with the therapy?
In a macroadenoma, we don't advise. Whereas in macroadenoma, we feel that persistent symptoms are there and the clinical examination is better. We won't advise frequent MRI examination. Otherwise, we go for a 6 monthly MRI examination.
Okay, so any of you a baseline MRI to assess whether there is a tumor or not, assess the size of the tumor, start around therapy, and later on follow with this patient at least 3 to 6 monthly. On 6 to 12 monthly, you consider doing MRI, as if I
Yeah, yeah,
am not
yeah.
wrong.
because it takes at least
And with
3 to 6 months.
clinical assessment.
Mainly is the clinical assessment in case of prolactinoma.
Okay, so can you please share your experience in how roughly how many patients with microprolactinoma are actually cured, the tumor actually resolved with the cabergoline, and in micro as well as in macro adenoma? A
That
rough
I
estimate.
Yeah, I have seen almost all the patients of macroadenoma being responsive to cabergoline. I've never seen any patient who is not responsive to cabergoline. And in macro also, I've seen big tumors being even washed away by cabergoline. And I've seen being operated only very few patients since the advent of cabergoline. It is a very dramatic drug.
Can you please tell us, tell the audience also that suppose a patient with microprolactinoma, what I actually want to understand from you, how long this therapy actually goes. Like suppose a patient comes with around 3 millimeter tumor, so what 3 years, 4 years, 5 years, how long you actually give the therapy to them?
Actually, if a patient with a macroadenoma, we usually refer the patient to the endocrinologist. We don't follow them serially with in our OPD because once there is no present symptom is hardly of our domain. Yes, in case of macroadenoma, we do work in conjugation with an endocrinologist to see whether the patient is being is responding or not, and hardly we see that the patient is not responding. I've seen only 1 or 2 cases who have not responded. That too after prolonged therapy, they also responds. Even we have previously been I've seen in my residency that the patient was operated for thinking it to be a non-functioning tumor, and ultimately it came up to be prolactinoma. And if there is a residual tumor, then too with cabergoline it do resolves.
Okay, sir, one thing, please, if you can tell our audience also, how safe is this transsphenoidal resection of pituitary tumor? How effective? How safe? Reason being, how what are the chances that we leave the residual tumor, or we may cause the hypopituitarism because of this surgery? So, what is your experience regarding this?
Transfemoral surgery is a boon to the patients, a very rewarding surgery, and you hardly ever have complications if you do it good. So, not to get feared about transfrontal surgery is a very safe surgery, and it's also as cabergoline has dramatic results. Transfrontal surgery has a very gratifying results. The main complication, if you talk about transfrontal surgery, is injury to the optic apparatus as well as the carotid artery. But if in good hands, it's also very rare. So, if you have, as I already told, prolactinoma assault doesn't as such require surgery. Yeah, there's very rare chances where we have to operate the patient, whereas we have other tumors, non-functioning pituitary tumors, as well as functioning pituitary tumors, other hormonal tumors, where we do need surgery. Non-functioning tumors is a separate entity. We will deviate from our current topic. It's a very big topic and it needs very much time to discuss. Probably we will discuss it at some other time.
So one last question, if you can permit me. If you have might have attended our presentation from the beginning, so this patient had a prolactin level of 38 nanogram per ml with Amenorrhoea Galactorrhoea Syndrome, with with a strong family history of brain tumor in Chacha and Bua, and because of which we had a brain MRI done in her case, in which we detected a space-occupying lesion in the right lobe of pituitary. So, what do you suggest? How likely is it that this hyper, because the prolactin level was not that much high, so how likely is it that this space occupying lesion is the related to this prolactin hypersecretion, or it may be possibility some non-functioning tumor and this hyperprolactinemia is due to some other cause? Or so what are the chances that these two findings are related, or they are not related to each other? So
First of all, we will like to know the addendum. Uh, attended the seminar from the beginning. I attended in the middle. But first of all, we will like to see which tumor did his father and chacha had, because there are very rare tumors which are familial in brain. So it's not like breast cancer that mother is having or the mother sister was having. So this patient will also have breast cancer, has a high probability of breast cancer. There are very little familial tumors that do goes into brain. Family history is also important. Secondly, as Dr. Sushil said, that if you are suspecting prolactin and the prolactinoma and the prolactin level is low, we should ask our pathologist to do it in serial dilution. So serial dilution is very important, because not apart from prolactin also there are other hormonal tumors also. If you find that clinical symptom are matching to some hormone secreting tumor and the hormone level is low, we have to ask the pathologist to do it in serial dilution, because if in normally it can prolactin can come low, but if you do it in serial dilution, the level will be high, very high. Because of the very high hormonal level, this level can come fallaciously low. So even it is a if it is a prolactin, if the prolactin comes high in this patient, so you can already take him on to cabergoline. And if the prolactin level is normal and other hormonal work level is normal, and the patient has no clinical features of any hormonal excessive secretion, you can simply follow the patient, because tumor with microadenoma, non-functioning microadenoma, you don't need to do anything. Just measure the size of the tumor. Your radio frequency can be helpful to this patient. It will destroy the tumor and the tumor will not grow. One other question which you asked me earlier about the incidence of hypopituitarism in patients of after doing endocrine transfrontal surgery. So there are only two hormones which is very important to the patient to sustain his life. One is cortisol level and another is the thyroid hormone. Other hormones are not essential for the patient, although they are essential for normal human being, but they are not essential for life. So after doing transfrontal surgery, we do care about the thyroid hormone as well as the serum cortisol level to see whether the patient doesn't goes into adrenal insufficiency as well as in thyroid status. Since we have removed the uh, pituitary, we won't measure the TSH, because TSH level will be fallaciously low. So we measure FT3 and FT4 or T3 or T4 in this patient, as well as serum cortisol level in the early morning status. We do supplement patients for a few days, and then we see whether the patient have started secreting his own hormone or no or not. And if the hormone level is normal, we withdraw the steroid which we give to the patient for a few days. So there is definitely a chances of patient and going into hypopituitarism after pituitary surgery if the pituitary is if the tumor is big enough. Any other question?
Hello, Dr. Sudhi.
Yes, ma'am.
Hello. Are you done with the discussion?
Yes, ma'am.
I
Ma'am,
want
any
to
questions?
highlight just important points which I could
Yes.
conclude from this discussion. One important point is patients even with very high prolactins may not have galactoria because of hypogonadotropic releasing hormone GnRH suppressed secretion, which leads to lower levels of estrogen, and priming of breast with estrogen is required for milk secretion. So patients even with high prolactin levels may not have galactoria. Another important point is the polymeric form of prolactin hormone, which I discussed about my case, that even patients with very high prolactin levels may not have any symptoms related to prolactin like cyclic cycles, irregularity, or prolonged cycles. Another important point is generally there is mild enlargement of pituitary during pregnancy. So there is no need of doing MRI during pregnancy just to check the size, the increase in size of pituitary tumor. Only when the patient presents with symptoms like headache or the visual field problems, then only we might think of doing MRI during pregnancy. And another important point is the sample collection for the prolactin measurement, and that should be done around 10 to 11 a.m., empty stomach preferably. So, these are the important points which I wanted to highlight. Anybody else? There are no questions in the chat box actually. And Dr. Meenal Garg has been attending the session very sincerely, and she has promptly and rightly answered both the questions asked by Dr. Sudhi. So, you can carry on the discussion, Dr. Sudhi.
Yeah, thank you very much. And I think enough of we should open the forum for an open discussion. So
Yeah.
anyone can ask any question from our faculties if they want to.
Yeah, I
Or
have a question for Dr. Sushil sir. Yeah. So, sir, we have discussed that we should start bullying, yeah, as per the indications. I just want to know that till what time you should continue with the capgoli once your prolactin levels become normalized.
Once you start capgoline and once the dose is stabilized, you continue the same dose. Repeat prolactin levels every 2 to 3 months time. If the prolactin is getting too low, then you reduce the dose of capgoline until you reaches a very small dose of capgoline, actually like 0.125 milligrams per week or 0.25 milligrams per week. Then you can make an attempt to stop. At the same time, you do an MRI to see that the tumor has regressed or not. If there is no visible tumor, then you can just stop.
क्या मैं रिक्रूट तो है नहीं था तुम्हारा यार कुछ पास
You can
can
stop capgoline.
can I, Dr. Mukta, can I ask one question, please?
Yeah, sure.
If a patient is having a macroadenoma and she is on capgolin, and the patient conceives during your treatment, so and you want to continue capgolin, so would you prefer to continue with capgolin or you would like to switch over to bromocriptine? As you said, bromocriptine is safer.
Yeah, for if we go by the safety data, then bromocriptine is safe, definitely safer, and we have the data for thousands of patients about the safety of bromocriptine. But as bromocriptine is not tolerated by many patients, so if it is not tolerated and we have indications like optic chiasma is being compressed or there is indication that treatment should be continued during pregnancy, then with the conjunction with the endocrinologist and the proper discussion with the patient, that though we do not have the randomized control trials and no elaborate data on teratogenicity, but till date there is no adverse effect is found on the fetus, and then patient should be taken in. Here, her choice should also be taken into consideration, and we can continue with capgoline with all these documentation.
Because generally capgolin is taken as the first line drug. So the patients who conceive are already on capgolin. So if we want to continue, we should switch over to bromocriptine or we should continue with capgolin. That is my question.
Actually, this should be as per the patient's choice also, because if we go by the literature, then bromocriptine is definitely safer than capgoline. But again, switching over and not tolerating could be a problem.
Yeah.
So if we should discuss all those things with the patient, and if patient is comfortable with the bromocriptine, then we can give bromocriptine, or else capgoline can be continued. We can take Sushil sir's view on the question
Yeah,
as
that's
well.
what I wanted Dr. Sushil sir to comment on this.
It's a tricky question, actually, to be very frank. There is no consensus in this. Dr. Mukta has already elaborated that society recommendations are bromocriptine, but the large number of observational data which says that capolin is pretty safe without any harmful effect on the fetus, neonate, or the pregnancy rate, miscarriage rates, or likewise. If you look at the congenital abnormalities reported with cabergoline, they are very minimal and very occasional. Normally, we continue cabergoline in under supervision and just do all the monitorings. I don't use personally bromocriptine because I do not find any sufficient evidence not to give tabgoline because of large amount of published data, observational data from various studies actually. So I normally continue tabgoline. I don't give bromocriptine. Those society guidelines tells you. I'm very frank with you. There could be difference of opinion between the experts and the guidelines. So I normally continue tabgoline.
Actually, we also have, as this generation, we just give capbolin and we have very little experience with bromocriptine. Though in literature it is said that it can even be given per vaginally, but frankly speaking, I have very few patients. I have this bromocriptine which was given. Otherwise, we used to give capbolin only.
We do have experience of giving bromocriptine in early days, as in 1988, 89 to 95, when capgolin was not there. At the same time, at that time also bromocriptine has the same questions actually. Then there's a term came, bromocriptine babies actually. That kind of term was given to the babies born in the mothers who were given bromocriptine during pregnancy. I don't see any big reservation about using cabergoline during pregnancy. I don't see that actually, very frankly.
Thank you, Dr. Sushil. Thank you, Dr. Mukta.
I have another question which is slightly different from pregnancy, but it's
Yeah.
a practical thing. As a surgeon, once dealing with a case of pituitary, I have discussed with Sudhi also, pituitary microadenoma, and that came out to be hyperprolactinemia followed by pituitary microadenoma, and that patient was posted for laparoscopic ovarian cystectomy, and anesthetist asked that you should do all the hormone profile like growth hormone, ACTH, GnRH, TRH, everything should be done for this particular patient. And I didn't find any reason to do the whole hormonal profile since clinically there was no acromegaly or anything like that. So what should be done ideally?
If it is a macroprolactinoma, there could be secondary hypocortisolism or hypothyroidism. So one should really go for these kind of stimulation. The person should be replaced with levothyroxine and or glucocorticoids actually. With micro, you don't have that kind of abnormalities, but definitely any tumor, functional or non-functional, small or large, they should be evaluated in the pre-operative period for any possible hypocortisolism and secondary hypocortisolism, secondary hypothyroidism. That is to keep the surgeon as well as an pretty safe actually.
Yes, sir. Thank you so much. Because I was just having that argument that why should I go for all these tests when she is very asymptomatic?
I
Majority of
think
these women are asymptomatic until you go for investigations. You must be seeing Sheehan syndrome walking around for many years before they have got adrenal crisis actually. So it's not unusual to have secondary hypothyroidism, hypocortisolism patients running around for years and it's safer to do this job. Safer to do this job. Yes.
Definitely. Thank you, sir.
Thank
yeah,
you,
I
Dr.
think
Mukta.
this was also one of the very valid point that we learned from this forum. I
I
was
think
also a bit confused, yeah, what to do, but like I sir cleared it in a very good way.
I think we can close the discussion here. It's already 1 hour and 46 minutes, and
Yeah, I think
and
we
I
have to
really
rush for a
want to
little
thank
bit.
Dr. Sushil, Dr. Mukta for giving their important inputs. The faculty from Mera, Dr. Sudhi, Dr. Meena, Dr. Chani, Dr. Rohit. Thank you so much for having such an important topic discussion with all of us. Once again, thank you all for everything. Thank you so much.
Yeah,
Thank
I
thank
you,
you,
really
Dr.
thank you
appreciate
Mukta.
very much.
all of
A
you.
Thank you,
sincere
Sudhi,
thanks to
for
a
inviting
sincere
us.
thanks to everyone. Sushil sir, Mukta, Anju ma'am, Dr. Rohit, Chani, Meena ma'am, and all those who have joined us on my single insistence and single invitation. They joined us, and I hope like this is a routine activity. We do it on a monthly basis. Last Friday of the month is fixed at 4 p.m. We start. So the next meeting is on breast. We will discuss about the chronic mastitis, various aspects, very, very, very confusing topic. And after that, we'll discuss about papillary thyroid cancer. So we have a huge list because like, I think learning is an unending process. And the more you learn, more you feel young and more you feel interested in what you are actually doing in your clinical practice. So I really enjoyed today's discussion. Each and every point I enjoyed, and I hope the others also have the same opinion. I thank you, sir, for the valuable
Thank you,
time you
Sudhi.
have
Thank
given
you,
to
Sudhi.
us.
It's a
I
great
know
pleasure
your
here.
hectic schedule. I know your
Great
hectic
pleasure here.
schedule. Still, you find out the time for us. It's a great pleasure, and like I'm very much
Thank
indebted
you.
for that. Mukta,
It's a
I know
pleasure.
how busy you are. You are stuck with so many stuff with PG teaching and other things. It was so nice to see you after such a long time, and
Thank you
I
so much,
look
Sudhi, for inviting. I also have learned a lot. Few of my queries at least were solved. Thank you so much.
we'll
Thank you.
always be keep in touch. We'll always take your help later on also. So thanks
Thank
for
you.
joining, and I request everyone we all may now disconnect, and with the promise that we will certainly meet in our subsequent meets as well. Thank you very much.
Thank you, Sudhi.
Okay.
Thanks
Thank
all.
you,
Thanks
Anju
Okay.
all.
ma'am,
Thank you,
for
Goodbye.
Sudhi.
moderating our session
Thank you.
in such a wonderful way. Like I was so fortunate that you are with us. Thank you, ma'am.
No, it was my
Please,
fortune
please.
that I was a part of this. Thank you so much and goodbye, everyone. Thank you.
Goodbye.
Thank you, ma'am.
Thank you, ma'am.
Thank you, Chani. Thank you, Meena ma'am.